Hello, I'm Nancy Kuntz, a child neurologist in Chicago. I'm a professor of Pediatrics and Neurology at the Northwestern Feinberg School of Medicine, and I'd like to talk to you today about spinal muscular atrophy and newborn screening. As many of you are aware, the Secretary of Health and Human Services in the federal government in the United States has an advisory committee that brings recommendations to the Secretary regarding potential newborn screening activities. The types of disorders that they recommend newborn screening for are those that have the potential to cause permanent damage or injury if not detected early, and for whom the injury begins to accrue prior to onset of clinical symptoms that would allow the diagnosis naturally. They also want there to be an effective treatment that has been developed so that there would be steps to take if the child is diagnosed early. And they also want there to be an accurate and effective, low-cost methodology for screening large populations for what inevitably are rare disorders, so that it becomes a welcome part of the healthcare system. Spinal muscular atrophy is an autosomal recessive disorder. Therefore, individuals have no function of SMN1. This is the major gene that creates functional SMN protein, which serves to support RNA splicing and axonal transport and other intracellular activities. The biggest impact of SMN1 and SMN protein being absent is on the motor neuron, but we're beginning to discover that these have impacts on all organ systems in the body, so that with more severe disease and with longer survival, we see other symptoms beyond just the hypotonia and weakness. We know from clinical experience that the number of copies of SMN2, the backup copy of SMN1 that has a single nucleotide base substituted, but the number of those copies of SMN2 is inversely related to the severity of the SMA. There may be other modifiers. It's not quite that simple. There is some overlap, but no question, there is that inverse relationship. Historically, people just described the types of SMA by virtue of the age at clinical onset and the clinical severity of the weakness. As people identified the backup SMN2 gene, it was realized that there was this inverse relationship. But as you can see on this table, there is overlap. So while the majority of individuals who have infantile onset have 2 copies of the backup SMN2, there are some individuals who have 1 copy or 3 copies. And the same sort of thing with individuals who are sitters or walkers. Most of the sitters might have 3 copies, but there are some who have 2 or 4. So that by itself is not definitive in terms of establishing prognosis, but it gives you a very, very good general rule of thumb. One of the problems with having the treatments available is that all of the clinical treatment trials have shown that the earlier the treatments have been administered, the more robust the response to treatment. But experience has shown us that there is, for all types of SMA, both infantile onset and less severe later onset, that there is a gap between the first clinical symptoms parents perceive and the time the diagnosis is finally established. So one of the things that we are doing this generation is working with clinicians and trying to get all of us to recognize SMA as a potentially treatable disorder and put it high in our differential whenever we have an appropriate patient that we're evaluating. One other approach is just to consider SMA as a perfect candidate for newborn screening so that we find all of the cases early in life. again, I want to show a little bit of data from some of the clinical trials just to remind ourselves in a very data-driven way that the earlier the treatments are provided, the better the children do. And basically what we're seeing here is a small international trial with 25 infants who were identified in the newborn period and began treatment for spinal muscular atrophy before 6 weeks of age. And what you can see here is that those children, and they're in the green or blue colors for their graph, their motor scale scores increased much quicker than those individuals who were in a treatment trial that began after the children were clinically weak and therefore diagnosed with SMA. The dark blue and orange graph lines indicate children who were treated by 7 months of age. And while they all improved, the degree of improvement was much less. And the dwindling gray line you see on the bottom were the untreated children, showing that from the time that spinal muscular atrophy is clinically diagnosed, all children regress with respect to their motor skills. Families tell very similar stories many times when you work with them to make a diagnosis of SMA, and that is that usually the neuromuscular team or neurologist that makes the diagnosis is not the first individual or professional who's been consulted, but there have been other encounters where children were either with well-meaning extended family members or primary care clinicians, and sometimes even from other specialists, encouraged to be patient and give the child some more time, see if they caught up on their own, see what nature would allow with respect to the child's motor development. And when there was no treatment available for SMA that was very appropriate, but it's not helpful to the child these days that now that we do have multiple treatments available. So if newborn screening is a way to identify the diagnosis of spinal muscular atrophy earliest, and we are just at the point where the recommendation has been made and the Secretary of Health and Human Services has passed on a formal recommendation to all 50 states that SMA be included in the newborn screening panel, it will take a period of time because it's really state by state that this recommendation is implemented. We do have a number of states who are already doing this. At the time of this filming, which is at the end of 2019, there are 12 states that have screening in place, either in pilot or in total. The good news is that there are many more states that are have plans in place with the legislature, the health department, and the professionals throughout the state, as well as the family support groups, working together to get the newborn screening implemented. Newborn screening will pick up the majority of these cases, but the absence of SMN1 only occurs in 95 to 98% of the individuals with SMA, which is a great percentage to have on your side. But it does mean that there will be a small handful of individuals for whom the clinicians will need to remain incredibly vigilant and incredibly suspicious that there may be individuals with SMA out there to be diagnosed. So I think that in order for clinicians to be prepared to find the final several percent of individual children who have spinal muscular atrophy, it's going to require a lot of conscious effort to keep spinal muscular atrophy active in our minds and at the top of a list of a differential diagnosis for infants, for example, who have hypotonia and weakness or poor feeding, or older children who look like they're not progressing to bear weight on their lower extremities, or who are walking and have proximal weakness that just looks like limb girdle weakness and could also be a muscular dystrophy. But to be suspicious and remind ourselves that there is treatment for SMA and therefore it should be tested for whenever there's a compatible phenotype. The diagnosis of SMA is best made by a direct test for SMN1. If both copies are absent, the diagnosis is made. If you're strongly suspicious and there's only and that test is negative, then what you have to, and it may well be if they've gone through newborn screening, what you need to do then is do a carrier test, because what the carrier test will do is count the copies of SMN1. If there are 2 copies of SMN1, the probability that you have one copy with a point mutation or something that's creating functional problems and a separate point mutation on the other copy is relatively low. So what you're looking for is one copy of SMN1, and then it can be sequenced to see if it's functional or not. So in summary, SMA is a progressive neurodegenerative disorder that primarily presents with low muscle tone and muscle weakness, decreased muscle stretch reflexes, and in infants, problems with sucking and swallowing and breathing with the intercostal muscles. It's due to the absence of SMN1 gene, but the presence of the backup copy providing a little bit of SMN protein is helpful, keeps people alive and allows survival in the absence of SMN1. The diagnosis and the prompt diagnosis is very important because we're in an era now of practice where there are multiple commercially available treatments for spinal muscular atrophy and more that are pending.